Okay, so this is going to be a brief rundown of the pregnancy component of ACEM's domain of medical expertise. The goal is to, provide just a single foundational source of the various topics in that syllabus for those getting ready for the fellowship exams. Now, there's no doubt that interstate guidelines are going to differ, and there's going to be plenty of important topics that you'll need to read around beyond this, but I'm just hoping that an intro to these different topics will just secure some understanding and can form a bit of a structure that you study around from. Pregnancy is only a small part of the curriculum, and it's important that your study time reflects that, but it's an area where there aren't a lot of resources, and I thought if we put them all in one place, that might be a value add. Now, if you are in the last few months before the fellowship exam, or you've got friends studying for the fellowship exam, if you send them the link or use this QR code at freeobstetricexam.com, then there's a 1 hour, 10 question SAQ practice exam, again, just aimed along the lines of the ACEM fellowship written. It's a tricky exam. It aims to find your gaps, but again, the combination of that exam and this talk just aims to be a core to your obstetric-related study. I'm sure everyone's familiar with the syllabus document. Going through it from an obstetric point of view, in some ways it seems a little disorganized and dated. There's a lot of terms here that aren't used anymore, and there's certainly conditions that are missing. So we're going to go through and at least mention or highlight every one of these, and we're going to try to roughly follow this order. And then there's going to be a few more conditions we'll talk about that have certainly been examined before and will be things you should be thinking about in your practice as consultants. A little bit about me really quickly. I used to do obstetrics for several years, both in a tertiary centre and then worked rurally where I helped set up a birthing service and practiced procedural obstetrics. After a while and starting a family, I sort of moved away from that now and just focus on emergency and retrieval medicine. So that's, the reason why I'm interested in clarifying some of these topics, because I've worked on both sides, spoken both sort of languages, so to speak, and hopefully I can bring some of those lessons across. So, as I mentioned, we're going to talk through all the topics, even if I feel they're not highly examinable. At the start, in terms of antenatal screening, again, I think this is fairly low yield from an exam point of view. I'm going to put some things on the screen that you can pause and have a read of, have a look at later. Essentially, just think about it from the point of view of there's history, examinations, and investigations being done at each phase of pregnancy. And then from a frequency of visit point of view, it starts fairly infrequent at 1 to 2 months apart in the first trimester, and then becomes 4 weekly, 2 weekly, and then 1 weekly at the end of the pregnancy, towards the end. The goals of antenatal care are just to ascertain the overall health of the woman, understand her social history, the family environment, any other lifestyle risk factors, to regularly monitor things like blood pressure, weight, BMI. There's obstetric-related physical examinations like palpating the abdomen and understanding the presentation, whether it be head first or breech of the baby, checking the fetal heart rate, etc. In terms of tests, there are numerous things that happen in first, second, and third trimester. In the first trimester, it's mainly about trying to find any significant maternal conditions that might require specific treatment in pregnancy. So this is a baseline blood panel, checking for anemia, doing a maternal screen for infectious diseases like rubella, hepatitis B, C, HIV, syphilis, checking that cervical screening's been done. And then often there's some first trimester screening for chromosomal disorders. It's absolutely not required that you guys understand the difference between these, and even this sort of commentary is probably a bit excessive, but given it's a syllabus point, we'll just talk about it briefly. In the midpoint of the pregnancy, there's a morphology scan done to identify any fetal abnormalities that women are screened for gestational diabetes, and again, their full blood counts checked. And then as you get later in pregnancy, the tests are mainly around getting ready for delivery, so checking blood pressure, checking urine, checking the growth of the baby, which sometimes involves an ultrasound. And I think that is probably sufficient at this point. From a physiological changes point of view, again, I think, there's a long list of things that change in pregnancy, but I think having a system-based approach or thinking about how the various physiological changes might impact critical care or critical illness. So if we just talk through airway, breathing, circulation, etc., I think that probably is sufficient for exam prep, and you can all read around from there. So from an airway point of view, I guess airway management becomes more difficult for several reasons. If we start even at the breast enlargement, that can cause the long handle of a laryngoscope to be obstructed, and just inserting the laryngoscope can be a challenge. There's internal airway edema at sort of most levels up in the pharynx, which tends to worsen Mullen-Party view and all the way down to the lower aspects of the airway. There's also the risk of aspiration from the relaxing of the lower esophageal sphincter. And I guess positioning becomes really important as well in these people, both from a airway manipulation point of view, or instrumentation, I should say, and even just the left lateral tilt that is probably warranted if you're doing a rapid sequence induction at late term. From a breathing changes point of view, as we know, there's an increase in respiratory rate. There's a reduced functional residual capacity due to the enlargement of the upward displacement of abdominal organs. There's increased oxygen consumption. And I guess these things all contribute to rapid desaturation during an RSI. So I think they're the important changes that you should be thinking about from a fellowship exam point of view. From a circulation standpoint, there's an increasing blood volume over time, or throughout the pregnancy, I should say, a higher heart rate, a higher cardiac output, and a general trend towards reduced peripheral resistance as the pregnancy progresses, such that healthy women tend to be a bit on the hypotensive side normally by the end of pregnancy. From a hematological point of view, as we know, there's a dilutional anemia. So whilst the circulating volume increases by up to 50%, the hemoglobin concentration tends to reduce. That also, especially through second and third trimester, and particularly postpartum, these women become have a relative thrombophilia, as we know about working these patients up for PE, both in third trimester and postpartum. So I think whether you're thinking about airway, breathing, circulation, heme, renal, liver, that's the way I'd approach the physiological changes of pregnancy, and think about how it would actually complicate a critical presentation for your exam and the rest of your career. Just a quick note, I don't think it's worth talking about fetal development. I'm sure everyone's aware there's an embryonic and a fetal phase, essentially from the point that pregnancy is diagnosed. I think that's not very examinable. There's a dot point there saying high-risk pregnancy. That's quite a vague term, because I guess high risk just denotes one of the complications are present. So we'll talk about some of the various complications of pregnancy that might be relevant to an emergency physician. And I think the high risk pregnancy dot point is something we just won't refer to anymore. This is a presentation that I'm sure everyone's seen many times. I think it is quite examinable, and it's certainly something that you'll see a lot as a consultant and be giving advice to members of your junior staff and nurse practitioners. I guess nausea and vomiting in pregnancy is really common. It can really impact quality of life for families, and there's a point there about it recurring in subsequent pregnancies, which I think's not so much a point you guys need to be thinking about. But from a diagnostic point of view, in most cases it is just morning sickness, but it's important to have a few causes up your sleeve, such as infectious causes, neurological causes, drug-related causes, even gastrointestinal causes. Just thinking about other reasons why someone might vomit, I think that's very examinable and relevant in real life. But as I said, most women tend to just have morning sickness. Hyperemesis gravidarum, you'll hear that a lot. I think the term is overused because realistically it's sort of less than 1 in 100 pregnancies. And you can think of it really as just really bad nausea and vomiting in pregnancy, such that despite oral medication, you still have significant vomiting, or there's significant weight loss, or ketogenesis, or electrolyte disturbances. I think these things are intuitive and they often form the indications for admission to hospital. So whether you pick the exact definition of hyperemesis gravidarum or just really bad nausea and vomiting in pregnancy, I think that's not super important either way. From a treatment point of view, it's important to emphasize the goal is to get these families home and improve quality of life. And that's going to involve, things like eating less more often, eating before you become hungry. Sometimes there's different foods that women will find less nauseating. Ginger's a stereotypical example, but I think there's often a lot of experimentation being done at home already, and I think just encouraging families to just eat less more often and eat the things that aren't making you sick. Some other things there that might be helpful. Then the hallmark of treatment really is around fluids, again with a preference to oral, and then antiemetics. And there's many antiemetics available. There's no real great head-to-head trials in nausea and vomiting in pregnancy, but I think it's important you have a good option for a dopamine antagonist, and they can be given orally, rectally, or intravenously, or IM. These serotonergic agents like ondansetron, again, sublingually or intravenously. Antihistamines are also commonly used, and even things like vitamin B6 or pyridoxine. So it's often worth having an escalating strategy from vitamin B6 or pyridoxine, which is just a simple over-the-counter medication, to then some oral antiemetics, to then parenteral antiemetics. And the fluid management also starts to go from oral to IV along a similar sort of trajectory. Another common presentation in early pregnancy is just vaginal bleeding. It's important to be structured with this presentation and at least think initially about whether this is pregnancy or not pregnancy related. Just to quickly tick off on the non-pregnancy related causes. Any genital tract lesion can give you bleeding. So that can be a cervical ectropion, which is largely a hormonal change to the cervix in pregnancy that we'll talk about later, but also cervical cancer, cervicitis, and vaginitis can all cause vaginal bleeding. It's one of the reasons why, despite the controversy around the speculum exam in early pregnancy, there's I think a reasonable argument that if a woman hasn't had a recent pap smear prior to pregnancy and they come in with bleeding, that visualizing the cervix to make sure there isn't a cervical cancer, for example, is value adding. And I've certainly diagnosed advanced cervical cancer when doing a speculum exam on someone I thought was just having a threatened miscarriage. So the overall yield is clearly low, and whether that's an emergency department intervention or just something that should be done in pregnancy after bleeding has occurred is something that I can stay away from at the moment, but just that is the rationale for some of it. From a pregnancy point of view, I guess we have viable intrauterine pregnancies, which is, a threatened miscarriage, failed intrauterine pregnancy, and there's various classifications of that between incomplete, complete, and missed. Ectopic pregnancy and pregnancy of unknown location. And just to talk about a PUL for a moment, that's just when there's a positive pregnancy test and no intra or extrauterine pregnancy seen on ultrasound. So these really are the group to focus on for the exam. But from a practice point of view, or there could be a question that just asks you to zoom out a little bit and think about a broader range of causes. From a consultant practice point of view, I think something that isn't spoken about very often is just having a clear approach to early pregnancy bleeding with hemodynamic collapse or PV bleeding plus shock. Really, that's only two things. It's ectopic pregnancy, which everyone is quite aware of, but it can also be due to a miscarriage, and that tends to be an incomplete miscarriage, which is causing either exsanguination and hypovolemic shock or cervical shock from some products of conception distending the cervical canal. I think the degree to which these women can hemorrhage with miscarriage is probably underappreciated, and so I think it's worth just having a simple approach to this. Now, for sure, it's possible that you can have vaginal bleeding and an allergic reaction, or vaginal bleeding with a miscarriage and overlying infection, but I think those are typically fairly easy to pick. But when you just have vaginal bleeding and shock, I think it's important to think about both these two causes. I've got a bit of an algorithm on the right, which we'll talk about in a moment, but I guess the importance of just thinking about these two causes is that they certainly both require resuscitation. One of them would warrant an urgent speculum exam, and they both probably need to go to theatre as a Cat 1 case. But from the other side, when you are receiving a call like this, and sometimes there's been historical disagreement about whether or not to get a formal ultrasound, which we can all agree is not going to be appropriate, the reason for that is to try and prepare the operating theatre and team for what operation is necessary. And clearly, either operation can occur, but from the point of view of getting scrub nurses to get equipment trays ready, it is important to understand whether you're setting up a laparoscopic stack or setting up for a suction evacuation and an EUA. So we'll talk through this algorithm. One of the things that I think is useful when these patients come in via ambulance or, they're pushed in on a wheelchair, when they first hit the bed in resus, there's a lot happening. They're getting cardiac monitoring, a blood pressure, a cannula. It's very difficult to get in and feel their belly or do a speculum examination initially. But I think it's a useful time to do a bedside ultrasound, simply looking for intra-abdominal free fluid. You can do more than look for just that, but I think all of us now in the modern sort of era are fairly handy, at least at fast scan. And whether there's free fluid in the abdomen or not is very much going to push you down a path of this is a ruptured ectopic pregnancy or this is a likely incomplete miscarriage. And while both of them are going to need blood product resuscitation, access, and an early call to theatre, you can pick the group that is more likely to need a speculum examination. And I think it is useful to look to either exclude or treat any retained products in the cervix, which tends to be just most easily done by using a speculum, a gauze wrapped inside some sponge forceps, and just wiping down across the external os of the cervix, which will help drag down the products and remove them from the os. Remember that these patients can just bleed also because they've got some retained products within the uterus, and you can actually use some uterotonics like ergometrin, and we'll talk more about that agent later in postpartum hemorrhage, but it tends to be a more effective drug you can use if you've got a bleeding miscarriage, as opposed to oxytocin where the receptors aren't really present on the uterus in the first trimester. So just hopefully a helpful algorithm for a new consultant practice or on the exam, but it really does shift the game a bit when there's hemodynamic collapse. To talk about miscarriage for a moment, I think it's important to realise it's just really common. It's often not discussed socially and in society very much, which often has families coming and mothers coming with a lot of guilt and a lot of questions around what they've done wrong. It's obviously something to discuss sensitively, but I guess just helping people and families understand that this happens more than most people realise, and often people they know or are friends with have probably experienced this, is just something to think about. From a clinical exam or clinical features point of view, you're likely to come across these either as someone presenting with symptoms or a incidental finding on ultrasound, such as a dating scan that happens where there's a failed pregnancy. There's historically been some definitions or classifications of miscarriage that pertain mainly to the cervical findings and ultrasound findings, as well as the presence or absence of products being passed. I've got a table up there, and I guess if you just think about the process of a miscarriage, it's fairly easy to work out which is which. So to rattle them off quickly, a threatened miscarriage has a live intruder on pregnancy and the cervix is closed with no products passed, which all makes sense for a pregnancy that's likely to continue. An incomplete miscarriage has an open cervix. There's some products passed, but not all passed, which is why the ultrasound will show retained products of conception. A complete miscarriage has now a closed cervix with products having been passed in an empty uterus on ultrasound, which again is very intuitive. And a missed miscarriage is one in which there's been no products passed, the cervix is not open, and the ultrasound shows a failed intruder on pregnancy. Other terms that you may hear is an inevitable miscarriage, but we don't really use that anymore. That historically was when the cervix was open, but the baby was still alive. And septic abortion or an infected miscarriage really just can be any of these where there is associated uterine tenderness, fevers, or systemic symptoms and discharge. And they're just treated with source control via suction evacuation and broad-spectrum antibiotics and supportive care in the way of hemodynamic support if required. The various parts of clinical assessment for early pregnancy loss are on here. They're quite obvious. I'll let everyone have a read and make any notes as required. I wanted to highlight briefly the ASUM, or Australasian Society of Ultrasound in Medicine, guidelines around what defines early pregnancy loss. And I guess this could be a tricky, tough MCQ, or it just can be useful to at least know where to find these definitions when you're working on the floor as a consultant and you see a report. A resident brings you a report to discuss whether this is a pregnancy that's going to continue or not. And these numbers are, if you have a gestational sac that's mean or average sac diameter is more than 25 millimeters with no fetal pole forming within it, then that's a failed pregnancy, and we used to call that a blighted ovum. And if there is a gestational sac and a fetal pole, but a crown rump length greater than 7 millimeters with no cardiac activity, then that's also a failed pregnancy. For anyone doing early pregnancy ultrasound, you'll probably have seen that the cardiac activity tends to be visible the moment that a fetal pole is visible, and they can be 2-3 millimeters in size, barely noticeable off the side of the yolk sac, and there's a central heartbeat that's easy to see. So I think just keep these terms in mind. We talked about anembryonic pregnancy, which is essentially what used to be called a blighted ovum. This is an ultrasound that I did showing a mean sac diameter of 26 millimeters, meaning that we check how big the gestational sac is in 3 planes, and then we work out the average. And in this case, there was no fetal pole, and therefore that's a failed pregnancy. I don't expect people to be doing scans for an embryonic pregnancy, but it's just a term that's on the syllabus. And when it comes to the treatment options for a failed intrauterine pregnancy or early pregnancy loss, there's 3 main groups. There's the conservative management, where women will just go home and have the miscarriage naturally. And there's some stats around how well some stats just around that in the column there. There's medical management, which involves using some vaginal misoprostol to try and, induce the miscarriage and improve its completion rate. And then there's surgical management, where a suction evacuation is done. Each of the groups have pros and cons, and they've been the target of RCTs over the years, which have essentially, I think, best summarised, shown that all options are reasonable, and outside a few different conditions such as hemodynamic instability or infection or the presence of a marina, then really a woman and family's choice is what's most reasonable to guide the decision. As I mentioned, if you have a woman with significant hemorrhage or a septic miscarriage, then really source control in the form of a suction evacuation done emergently is really important. An ectopic pregnancy really is the main fear we have as emergency clinicians. It's something that everyone's pretty familiar with. The incidence of them is rising, and it's now as common as 1% to 2% of pregnancies. Most occur in the tubes, and there's some images there of the different parts of the tubes where they can occur. The sort of assisted reproductive technologies are an increasing incidence of tubal disease probably account for the rising incidence. And then it's important that you have at least heard of, I guess, for both your practice, but also for maybe an MCQ, that there's such a thing as a heterotropic pregnancy, where you have a twin pregnancy with both an intrauterine and ectopic pregnancy. The reason this is important is that whilst it's extremely rare in natural conception, it can be as high as 1 in 100 or even less than that in the setting of assisted reproduction. So just something to pop in the back of your head if you're seeing someone with early pregnancy bleeding or pain and a single intrauterine pregnancy, particularly if you're doing a bedside scan, and just realise that, have it on your radar and be careful discharging patients either on assisted reproduction or if they've got symptoms that are excessive of what you'd expect. Ultrasound findings are often examined, and I guess from a most common point of view, usually the ultrasound findings are that you don't see an intrauterine pregnancy and you do see an adnexal mass. You can confirm the diagnosis if there's a yolk sac or fetal pole seen in the ectopic tissue, and you certainly can see live ectopic pregnancies. And then indicators of rupture are some free fluid in the pouch of Douglas, and you can see that a small slit of that on this image, or more concerningly, free fluid in Morrison's pouch, which, as you'd know from trauma, requires a fairly significant volume hemoperitoneum, and that really suggests that going to the operating theatre in the next hour is important. Here's some just pictures of an ectopic pregnancy. You can see a full gestational sac and fetal pole in the adnexa on the left, and then you can just see the vascular pattern around the ectopic pregnancy on the right. And these are just some images showing free fluid. So on the left, that's a transvaginal image showing free fluid in the pouch of Douglas, and on the right, that's essentially a positive fast. So it's a right upper quadrant view with fluid there in Morrison's pouch that you can see. The management of an unstable ectopic pregnancy, I guess that's what's most examinable in an SAQ. It's most important to execute in your clinical practice. And essentially that's just early fluid and blood resuscitation, some simple supportive care like pain relief, and going to theatre for salpingectomy, which tends to be laparoscopic. One of the points that could come up on the exam, or at least could burn you in clinical practice, is that hemoperitoneum in and of itself can prevent the tachycardic response to hypovolemia. So just be a little bit careful if you've got someone who you suspect could have an ectopic, you suspect it could be ruptured, but the vital signs like the pulse rate is 60, 70, not what you'd expect from the degree of hemorrhage they might have. So again, just there's all these little tricks that are in practice that might trip you up, and just make sure that you've thought about these different issues and work that into your exam prep. Okay, so we're going to talk about some problems or emergencies in later pregnancy, and preeclampsia is one that you will know about, will certainly be examined, and is something you need to have at the forefront of your mind when working in the ED, particularly even fast track. Now, before we move on to preeclampsia though, I just want to address the syllabus point of pregnancy-induced hypertension, which is now known as gestational hypertension. That's a condition in which women develop new elevated blood pressure, more than 140/90, after 20 weeks, but there are not any of the features of preeclampsia that we're going to talk about shortly. So these women are still monitored closely. They're still considered high risk because they have a very high chance of progressing to preeclampsia as the weeks and pregnancies progress. And the other thing is that they're commonly induced as soon as the baby gets to term. But again, that's, I guess, obstetric management, which is less important for the emergency practice or your just clinical career. And so we'll just go back on now with preeclampsia. So this is a disorder of the placenta, the details of which, as you dig into the literature, are a bit poorly understood. Essentially, for ease, the best way to think about the diagnostic criteria is to take high blood pressure, which is more than 140 or a diastolic of 90, at over 20 weeks gestation, and any of the end organ dysfunctions that can occur with this disease. So those organ dysfunctions include kidney involvement, which is most common, and we tend to test for this in the form of doing a protein-creatinine ratio, looking for proteinuria, and the important number there is 30. But you can also get an elevated creatinine or oliguria with preeclampsia. Neurological dysfunction, so that can initially simply present with headaches, which might come to fast track, visual changes, and then on examination you might see significant hyperreflexia or clonus. Eclampsia, which I'm sure everyone's heard of, is when you have severe preeclampsia and seizures, and we'll talk about that a little bit later. Other end organs that are important to remember include the liver. So it can have a spectrum of disease starting at just a simple transaminitis all the way through to a subcapsular hematoma and or liver rupture, which I've seen despite a fairly short career in obstetrics, so it does occur. And then there's hematological problems such as hemolysis and low platelets. Put together, you might remember that the condition called HELP syndrome, which is essentially a severe phenotype of preeclampsia in which you get hemolysis, elevated liver enzymes, and low platelets, just as a side note. Other end organ dysfunctions include pulmonary edema as well as fetal growth restriction. So I think if you think about preeclampsia, if you see someone with high blood pressure, you want to think about each of those organ systems and how do I either examine the patient or do a simple investigation that's going to tick that list and exclude them. From a management point of view, whether you have preeclampsia or eclampsia, the cure is delivery. When it comes to preeclampsia, which we'll just talk about first, there's a balance between maternal condition and the degree of prematurity of the baby. So this decision is very straightforward around delivery when mum's really sick and the pregnancy is progressed all the way to term. So there's no value to be added by progressing with the pregnancy. But you could imagine that a mum who's not quite as sick and the baby that's very early leads to a situation in which these women are admitted to hospital and monitored really closely just to try and get all of that additional fetal development that is associated with significant fetal morbidity if it doesn't occur. Some simple things to remember about management is the need for blood pressure lowering. So the Australasian guidelines suggest lowering when the blood pressure is greater than 170 on 110. Many units, as in birthing units, will have a threshold of 160 on 100. But you can remember those figures. And the simple way to remember the therapeutic endpoint is that you're just aiming for essentially 140 on 90, which is the definition of hypertension. It's important that magnesium is used, and that's done in preeclampsia as seizure prophylaxis at a dose of 4 grams over 30 minutes, then 1 gram per hour. It has other benefits as well. In extreme prematurity, there's also some improved neuroprotection that occurs. Now, eclampsia is something that could easily be examined, and it's, again, something that you will come across in your clinical practice. It's important to understand that the seizures themselves tend to be short, self-limiting, generalized tonic-clonic seizures. They don't tend to present with any focal features or with prolonged seizures or status epilepticus, but it is possible. I think when focal features are present, or if there are, there's a prolonged seizure or status, then that's someone you're going to need to undertake further investigations of, like neuroimaging acutely, to make sure they haven't had an intracranial hemorrhage or another cause that is leading to their prolonged or atypical seizures. Like preeclampsia, eclampsia's management is delivery, but it's done then on that day. It's not monitored or progressed for gaining extra weeks of gestation. So the delivery occurs that day. Magnesium is used again. I think about status epilepticus in pregnancy, especially if there's elements of preeclampsia, and I think the most basic way to approach it is just to give magnesium and follow the status algorithm. So benzos are useful in seizure termination. Levetiracetam is, I think, the most sensible option for status, and certainly in pregnancy it's reasonable. So I think just having a simple approach that you can pull from another common area of your practice is good for both your clinical career as a consultant and the exam. Antepartum hemorrhage is essentially bleeding that occurs vaginally after 20 weeks. And it happens not uncommonly, but there's a spectrum of severity. One of the things that's important to look at there is that a major antepartum hemorrhage is more than 50 mils, which is, not a very large volume of blood, and we'll talk about why that's the case. There's probably two reasons for that. And then I guess you can see that as the antepartum hemorrhage is more than a litre, I think we can all agree that's an absolute obstetric emergency. We'll talk about some of the conditions that cause an antepartum hemorrhage, and placenta previa is one that should come to mind or be part of your differential. Essentially, that is where the placenta, as you can see on the right, is below the baby and tends to be covering or very adjacent to the cervical os. The way to differentiate this in general is that it tends to be painless bleeding with no uterine irritability or tenderness. And even a small bleed with someone who has placenta previa can be, a warning that a larger bleed is coming soon. As the cervix dilates, that exposes more of the underlying placenta to just freely hemorrhage. And the risk or phenomenon of a herald bleed is part of the reason why a 50 mil antepartum hemorrhage is considered significant. From a treatment point of view, it goes without saying for all of these obstetric emergencies that you're going to call for help, get advice, admit to obstetrics, try not to be the only one looking after these women and making a decision. So just assume that all of the normal calling for help is part of the treatment here all the time. You're going to resuscitate these people hemodynamically, which needs no real explanation to this group of people, and then they're going to have an emergency cesarean section if they're unstable. If they're diagnosed just in antenatal care, which certainly happens and monitored after their morphology scan, then if they still have a persistent placenta previa at term, they'll have an elective cesarean. Placental abruption is another condition that is important to consider in antepartum hemorrhage, and it occurs where there's a separation of placenta and some bleeding from those exposed vessels. And that does two things. Obviously, it causes bleeding. It can cause some localized tenderness and uterine irritability, but it also reduces the functional surface area of the placenta. So if these are small or happen early in pregnancy, they can have problems later in pregnancy with fetal growth restriction, because not all of these abruptions are massive and causing instability from the outset. Placental abruptions can just occur spontaneously. They are, in some instances, associated with other conditions or substance use, or they can be following trauma. It's important to realise that it's not only direct abdominal trauma that can cause a placental abruption, but even a minor deceleration or seatbelt injury. And the way that you sort of differentiate these or pick these is when there's abdominal pain and certainly uterine tenderness or tightenings occurring, which also would suggest an abruption rather than a placenta previa or other cause. one of the things to understand, and there's a concept of a concealed versus a revealed abruption, is that you can have abruptions with no vaginal bleeding, and they just present with bad abdominal pain and uterine irritability. And that just occurs if you imagine the surface area of the placenta. If there's a small area in which the outer edge of the placenta is still attached and the bleeding is contained and occurs in behind the placenta there. So you don't get revealed hemorrhage, but you do get the problems with fetal perfusion and the abdominal pain and tenderness. For placental abruption, again, resuscitation is important. Probably for the MCQ, it's important to understand that DIC can occur early with placental abruption, and then really it comes down to the maternal and fetal state and condition, with a plan to deliver, as soon as possible and via cesarean if either person is compromised. But sometimes, if it's a small abruption, these women can be induced and have a vaginal delivery. Just to talk about and round out your differential diagnosis of APH with some terms that are in the syllabus. On the top left, a uterine rupture outside of trauma tends to only really occur during labour in a woman who's had a prior cesarean section. So you can see a uterine rupture of the lower segment just there. Below that, a vasa previa is really important. It's a condition where there are fetal blood vessels running through the membranes, and when the membranes rupture, those vessels are torn. As you can imagine, being fetal in origin, that hemorrhage doesn't have to be very big to cause fetal death, and this is another reason why the 50 mils of APH is considered significant. On the other side, we've got a cervical ectropion. This is what it looks like on a speculum examination, and that's essentially where the tubular epithelial cells of the endometrium, prolapse out to the external os of the cervix, which is typically a more stratified squamous epithelium, so it just has a different appearance. It's not problematic, but the issue is it's friable, and particularly post-coitally can lead to bleeding in pregnancy. You can see a cervical cancer there, which doesn't need further explanation, and there are some conditions here in the middle where the placenta abnormally adheres to the uterine wall, and depending on how far that it migrates into or through the uterine wall, it can have a slightly different terminology. Isoimmunisation is one of the dot points on the syllabus, and essentially the concept is that we're pretty familiar with it based on our use of anti-D, but in pregnancy, women are screened for their ABO blood group, their RH status, and the presence of any atypical or less common red cell alloantibodies, and there's many of those. Common ones other than RH, anti-C, K, but really, again, I don't think this is particularly examinable. Just know that it's an issue, and I guess we are involved with isoimmunisation prevention when we use anti-D to cover for sensitizing events. So this is just a small part of a larger concept. The reason we do this is because with isoimmunisation, you get hemolytic disease within the baby, which can lead during pregnancy to fetal anemia, and these babies can be born or develop in utero high output cardiac failure, and these babies can die. So it's really something that when these abnormal blood groups are noticed, or if they're picked up randomly in the ED, they really do need to be escalated and referred for, high-risk pregnancy management. Preterm labours are more core obstetric emergency that we saw. Certainly you will see this rurally. These women will tend to present straight to the birth suite in a larger centre, or if you work in retrieval at all, you might be asked to transport these women. Essentially, this means that before 37 weeks, which is considered term, you have uterine tightenings, abdominal pain, and possibly the early cervical dilatation of labour. Sometimes there might be some vaginal bleeding, just a small mucousy amount, which tends to be referred to as a show. And fluid loss from ruptured membranes can also be a feature in preterm labour. The assessment of preterm labour is pretty sensible and it's in front of you there. Some of the things worth just reminding you for the exam, because I'm sure that the things on the list there will come to you freely, are that the key tests for essentially deciding if someone's likely to deliver or not. There is a bedside test called a fetal fibronectin, and there are other brands and tests that you can use, but essentially that tests for a substance that's secreted just prior to labour occurring, and it has a good negative predictive value. So that's a test that might come up on the exam, and then cervical length. So if the cervix is long, more than 2 to 3 centimetres, then it's very unlikely that this is going to progress to actual preterm labour, as opposed to just threatened preterm labour. But, cervical length is very important. In terms of the management of preterm labour or threatened preterm labour, there's a few key aspects. So the most important intervention is corticosteroids. And I guess the rationale for that is to try and boost fetal lung maturation, but also it reduces the risk of other fetal complications like intraventricular hemorrhage and necrotizing enterocolitis. It's typically using betamethasone, which at a dose that I think you need to know for your exam, and dexamethasone is also able to be used. Tocolysis is performed, so that's essentially when you use a medication to try and stop the uterus from contracting. And again, I think this is very examinable. So I think, understanding that you can use nifedipine 20 milligrams 3 times over the first hour and then, 4 times a day is important. And really the end point though is to try and have 48 hours of tocolysis to facilitate the full corticosteroid administration. There are some other options like salbutamol and terbutaline. They both work similarly, but really at least having a dose or an understanding of the nifedipine, I think, is important for the exam. Antibiotics are given during preterm labour, and then if the gestation is less than 30 weeks, magnesium is used for neuroprotection, as we discussed earlier. Usually these women are transferred to a centre where there is a neonatal intensive care unit, but that's again something you're going to consult on and speak to a retrieval service. And again, just want to re-emphasise, like I said earlier, that none of this is happening purely in isolation, as you all know. We will discuss it as if you're the solo decision maker, but really, as usual, calling for help, getting someone else to sort it is usually the goal as an emergency physician. Imminent birth's worth talking about briefly. You've probably had this in your emergency practice, and it certainly could, I guess it'd be a rough OSCE. It's possible that it would come up in the exam, but certainly in your career this will happen. You usually get a phone call that, someone's coming in with a, likely birth. It happens a lot to the ambulance staff on the road where they don't make it to hospital. But I guess you could get a call from triage that someone's in the waiting room and they're going to rush them in shortly. I think a good structure to any kind of preparation is think about staff, space, and stuff. So staff, as we said, you're going to call for help. That's going to be outside the department, both to the obstetric unit for O&G, regs, consultants, midwives, paediatricians or neonatologists, whoever can come and help. But also within the department, there's a lot of emergency nurses who are midwives and some doctors that have obstetric experience. So really just getting people that can help. From a space point of view, it's usually in resus, and you certainly need lighting and a bit of room. But I guess just sometimes screens for a bit of privacy can be useful. In terms of stuff that wouldn't usually be in resus, I guess getting the resuscitaire ready in a birth pack and at least a single vial of a uterotonic like syntocinon to prevent PPH is going to be useful, at least in the initial phase, while the business starts to happen and others are starting to get additional equipment and drugs and help. In terms of how do we manage mum and assess mum, putting a cannula in is probably going to happen in resus, but just realise that if it's really progressing and you're probably better off just helping with the delivery than trying to get in a cannula. Women who are low risk deliver with no cannula regularly in birth suite. And so just, I guess, prioritising your interventions is important. Doing a set of obs is important, and a fetal heart rate, which I think is most easy just with an ultrasound machine, because it tends to be just as easy to see the heart as it is to find it with a Doppler. And I think I wanted to highlight a picture of checking whether it's head first or a breech, because I think that's low-hanging fruit clinically. So if you were to do a transverse pelvic view like you would in an EFAST, the picture that you can see there demonstrates a cephalic or head first presentation where you can just clearly see a hyperechoic skull. In my obstetric career, there were a lot of times where women had abdominal palpations and even vaginal examinations confirming a head first or cephalic presentation, only to then undergo a breech delivery unexpectedly. So I think it's just a really nice thing to confirm that that's what you're dealing with if the head isn't obviously on view. If it's a breech presentation, it's just a lot less clear. So I think if you can definitely see a skull, then it's head first. If you're not quite sure, then I guess you're in the game of the lottery. A vaginal delivery, when it's going smoothly, you probably don't need to do very much. Obviously, we would rather these women make it to birth suite, but if they're a woman who has the head on view or the labia parting, it's probably worth delivering where you are. If it's a woman who's had multiple babies who said this baby's absolutely coming right now, then you'd be brave to put that woman into an elevator or move them through the hospital. So I think just take some feedback both from your examination and from the mother. It's important to check the fetal heart rate after every contraction, so that's every couple of minutes at the end there. And then if you're thinking about episiotomies from when you trained, it's just probably not appropriate. So there is nuance to when episiotomies should be done, and they were done almost routinely in the past. There's perhaps been a pendulum swung too far in the other direction, but I think understanding that, looking for periurethral blanching as an indicator of potential complex perineal trauma occurring is just a bit outside the scope of what you're trying to do. So I think just don't worry about those. And then there's some pictures there that just talk about the different stages in labour and delivery and the way that the baby descends, rotates, maintains a flex position, and then finally births via head extension. You can look through those. This is a video that just shows a normal vaginal delivery, and what you'll see is the mum's going to be doing all of the work. It is worth, when the baby is crowning, to just try and slow mum down a little bit, get them to pant or blow out a candle, just to try and reduce any trauma to the perineum at that point. Once the head is delivered, you'll see it rotate, and then you'll be able to just gently unlock and deliver the anterior shoulder, and the rest of the baby should follow and can just go up onto mum if it's in good condition. In terms of the cutting the cord and the placenta, I think the important thing to understand is there's no rush for these things if mum and baby are doing well. In terms of the cord, I think just cut it nice and long. The last thing you want to do is cut it so short near the baby's belly that it can't be used for an emergency vascular access. I've got 10 centimeters there. It obviously doesn't need to be that long, but just keep it plenty long so that you can trim it later to the length that you need. In terms of the placenta, again, there's no rush. It tends to take 5 to 30 minutes longer if it's a first baby. And you really want to be careful trying to deliver the placenta before you see any signs of separation. So those are, you get a little rush of blood, the cord lengthens, and the uterine fundus is supposed to rise, but that's a bit hard to pick, I think, if you don't do this very often. What I will usually do is I'll actually take the forceps that I've clamped the cord with and clamp it right just below the introitus, or the vaginal opening. The reason I do that is it's then really clear to see when the cord lengthens. Otherwise, you're just looking at a long bit of cord and trying to work out how far it now is out. But if you clamp just outside the vaginal opening, you'll notice that it definitely lengthens associated with that little rush of blood. Now, fetal distress is obviously a really important topic in obstetric care. It's, I don't think, particularly relevant for the emergency physician, although I have seen CTGs in significantly older exams. We're just going to talk briefly about it because it is a syllabus point, and I'm going to demonstrate what a normal cardiotocograph has. So really, I guess, in terms of fetal monitoring, there's a couple of things that can happen. Just a fetal heart rate, looking for a normal rate between 110 and 160. A CTG, like you see on the right, but also in labour and certainly not in the ED at all. You can take a small amount of blood from the baby's scalp and then test it for either pH or lactate. So that's just a bit of a zoomed out view of fetal monitoring. I think it's potentially reasonable to ask a question on the exam about a CTG, but it could only be extremely basic. Essentially, the hallmark of a normal CTG is that you've got a normal heart rate. That scratchiness that you see is variability. So you can see that sort of heart rate variability minute to minute, which is, should be more than 5 beats per minute. Accelerations, which are those little mountains that you can see there where the heart rate goes up sort of 20, 15 or more beats per minute. And then not having decelerations, which are, I guess, the opposite of an acceleration when you look at it. And I'll show you a couple of images quickly in a moment. There's obviously a caveat that some decelerations are fairly normal, and there are different patterns well beyond the scope of this talk as to what constitutes a higher risk of current fetal hypoxia. Couple of images you can see on the left is our normal CTG again. On the right, we see, a CTG with reduced heart rate variability. There's less scratchiness and a lot of decelerations. So this would just be an obvious example that I suppose could happen on an ED exam that's really obvious. The other difference you'll see there is on the bottom line, there is no perceived or measured contractions on the left, and there are frequent contractions on the right. So two very different CTGs. If it was to ever come up on the exam, I think it would be extremely obvious. Here's another example where there's an elevated baseline heart rate and reduced variability. Okay, so preterm, pre-labour rupture of membranes, or PPROM. This is important. It's certainly a exam topic on the syllabus. It essentially refers to when the membranes rupture before the onset of labour. And when it comes to preterm, that's before 37 weeks. The way this presents is that there's typically a rush of fluid, or someone thinks they've broken their waters, and the diagnosis is confirmed by, I guess, getting a story and then doing a sterile speculum examination. This is not something you tend to do in the ED, and PPROM is probably just something to be aware of so that you can refer appropriately. But the way in which the sterile speculum exam diagnoses ruptured membranes is that you have a woman lie down for at least half an hour, and then when you put the speculum in, there will be some pooled amniotic fluid that in the vagina that will spill over into the lower blade. So that is the way ruptured membranes, either at term or preterm, is diagnosed. The main differential for PPROM is urine leak, which becomes more common in late pregnancy. And I guess the things that are important to understand are acutely, the issues are cord prolapse, which we'll discuss a bit later, and then preterm labour and the resultant issues with prematurity. But other ones that are important include infection, including and up to chorioamnionitis, which is the infection of the womb when the baby is still present. In terms of some of the other syllabus points, malpresentation and malposition are on there. I'll define those terms just so you realise it's not particularly relevant. So malpresentation essentially refers to when the head is not the presenting part, and we will talk about how to manage a breech delivery at the end. But malpresentation and the various forms of it, I think, is just not examinable and not relevant to an emergency clinician. Again, malposition. So malposition is when for example, in a cephalic or head first birth, the most common position that the head is in is where the back of the head is facing the front of mum. or an occipito-anterior position. And when this is reversed, or an occipito-posterior position, that's associated with slower progress of labour and more likely to have obstruction and instrumental delivery or caesarean. Hopefully, just by explaining those terms, despite the fact that they're on the syllabus, helps you realise we really don't need a deep dive review for that, for the purposes of either being an ED consultant or doing your fellowship exam. Nuchal cord is essentially when there's, some umbilical cord around the neck, and that is, can certainly be problematic in utero and lead to issues of either growth restriction or intrauterine fetal death. Essentially, where it might be relevant to your practice if you are involved in an imminent delivery and the head is born with some cord around the neck, then if it's nice and loose, which it usually is, you can tend to just be able to loop it back over and gently release it. But if it's really tight or there's multiple loops, then the practice will tend to be to clip those loops of cord and cut them. And obviously at that point, the baby no longer has a blood or oxygen supply, so it needs to be delivered fairly rapidly. Shoulder dystocia is a complication of birth that is very examinable and certainly is something I'm sure everyone's concerned about if a baby's born in front of them. I think the important thing to just really hit home, especially if you have a look at that image, is that this is a bony entrapment of the shoulder behind the pubic symphysis, and you can see that just there on the image. Less commonly, it can be due to the posterior shoulder being impacted against the sacral promontory or the sacrum there, but that's the minority of cases. The way you'll pick up a shoulder dystocia as present is that the head will deliver and then the shoulders won't deliver. Sometimes the head will tuck back in, and that's called the turtle sign. But essentially, any time that the baby is born and the shoulders are difficult to deliver or don't deliver easily, then this is a shoulder dystocia. And the concern is that the child, for a variety of reasons, is at risk of rapid hypoxia and acidosis. And that can obviously lead to hypoxic ischemic encephalopathy. You will learn or be already familiar with a systematized approach via, for example, the helper mnemonic, which I'll show in a minute. But just a simple approach here that I think is useful is, again, like always, call for help, get someone else to come and sort it for you. But expect a neonatal resuscitation because these children are often born flat. Lay the woman down and lift her legs up, knees to nipples. The reason to do that is because that opens the pelvic outlet further, which might make the anterior shoulder or more likely to pass below the symphysis. The next thing to do is actually push suprapubically to try and squeeze the shoulder down and under. And then I think for the emergency clinician, the next play is to roll her over on all fours and just try to deliver the baby in that position, because that repositioning allows everything to be disimpacted. And then you can essentially, by bending down into that position from all fours, you can achieve quite a significant Macroberts maneuver, or the legs up position that we just discussed. There are other maneuvers, but if you try and remember anything in your practice, these things will get you out of trouble probably 80% of the time. So here's the helper mnemonic, and you can read in and around that. But as I said, I do think that calling for help, legs up and lying flat, and then suprapubic pressure followed by all fours is the way to get out of trouble as a non-obstetrician. And hopefully by that point, help has arrived. Uterine inversion, again, is a syllabus point, and it is typically iatrogenic. And what I mean by that is if you don't wait to deliver the placenta until there is separation, so either a rush of blood, cord lengthening, then you can cause a uterine inversion where the uterus is prolapsed and pulled out through the vaginal introitus. That causes lots of issues. It is extremely painful, and it can cause shock due to mostly a massive vagal response. It's important that in these cases you push the uterus back up into the pelvis. Don't remove the placenta because that can cause profound hemorrhage. And then just do bimanual compression, which we'll talk about in postpartum hemorrhage. The reason, I could imagine that if you're in a regional centre with no help and you've got a patient screaming with a uterine inversion, they may need deep analgesia or even dissociation to sort this. It's very difficult to remember or think about tocolysis as a way of more easily facilitating the replacement of the uterus, but just know that it is an option, and it obviously has its own trade-offs in terms of its own hemodynamic effect depending on what you use. The obstetric management of these will be going to the operating theatre, having a manual removal of placenta, and essentially often having uterine balloon tamponade put in, or at least examination and checking for significant postpartum hemorrhage after the placenta is removed. In some instances, the patients will actually have a laparotomy and have a surgical reduction of the uterine inversion. Again, this is beyond the ACEM syllabus, but just for your awareness, in which you essentially get clamps and pull the telescoped uterus back up into the pelvis. Cord prolapse we talked about earlier. You should think about it any time a woman ruptures her membranes. Within the birthing suite, there's a rule that any time there's a potential rupture membranes that you really need to check the fetal heart rate and check for a cord prolapse. It, as I said, can cause fetal death mainly just due to cord compression. And the management, if it happens, and I think this is potentially examinable, is you essentially use your gloved fingers to push the head or whatever the presenting part of the baby is up off the cord and off the cervix, just so there's room for the cord not to be compressed. What then happens is that these women will have a Cat 1 cesarean section, and you'll actually go all the way to theatre on the bed and have your fingers pushing the head up all the way up until the point that whoever's doing a cesarean will actually put their hand in, lift the head up and out of the abdomen. So that's sort of what you can expect if you're ever involved in a cord prolapse. Postpartum hemorrhage, I guess, is obviously a very scary complication of pregnancy. I'm just going to go back and start postpartum hemorrhage again. Postpartum hemorrhage is, a really frightening complication of pregnancy, and still is a leading cause of maternal mortality worldwide. It's defined as more than 500 mils of vaginal bleeding after birth. It has a higher definition in the setting of a cesarean, but you shouldn't really be seeing post-cesarean women in the ED. The causes, which most people will be aware of, are able to be remembered via the 4 T's, which stand for tone or uterine atony, trauma or genital tract trauma. And this can be not commonly a perineal tear, very commonly a vaginal wall tear, and these can have significant hemorrhage, or a cervical tear. Now, cervical tears are different in that they might have an arterial source of bleeding, but they aren't particularly common. So, in practice, it's probably more likely than anything that it's a complex vaginal wall tear that in a rural centre or without help, with some difficulty, you could potentially place some hemostatic sutures, but that's a conversation for another day. So tone trauma, tissue being retained placenta, as well as thrombin, which is just a memory aid for coagulopathy, which is either primary or secondary due to some medications that women are taking, or a consumptive coagulopathy that can occur just in significant bleeding. The management is to think about the 4 T's and treat whatever's present, to rub the fundus to try and get the uterus to contract, and obviously, as usual, call for help. Get access and resuscitate. This is ideally done with blood products. TXA has become routine practice, and you can speak to your DMTs about whether you'd use that on the exam. I think probably yes. There's more nuance with further RCTs following the woman trial, which probably suggests, particularly in tertiary centres, it doesn't make a lot of sense. But I guess the ED and rural hospitals in the retrieval setting are all variants of an austere setting where you want to have, I guess, a more aggressive management posture. Some drugs for uterine tone, which we'll go about on the next page, are important. And then I want to talk briefly about bimanual compression. So obviously it goes without saying that this is an intimate procedure. It's probably quite uncomfortable, and it's relatively invasive. I've been involved with large postpartum hemorrhages many times, and I've only used bimanual compression probably 3 or 4 times. But I think with good communication and a good rationale, that this is a really useful tool to be used as part of the hemorrhage control. And I guess if we were to just borrow some concepts from trauma care, it's really important in the unstable patient we don't tolerate ongoing blood loss. And if it was an extremity or junctional hemorrhage or some other form of bleeding, that the goal would be control, even if that was with digital pressure. And so obviously this is a more sensitive form of direct pressure, but it is a life-saving skill that I think you want to think about and institute before you lose control hemodynamically. In terms of drugs for postpartum hemorrhage, there's ergometrin, which is an alpha agonist. There is syntocinon, which is a synthetic oxytocin, which is used both as a bolus and even an infusion. There's also carbetocin, which is coming as a heat-stable alternative. Misoprostol is becoming less used, but is a prostaglandin, which can typically be used rectally. And then prostaglandin F2 alpha is one that when I first did obstetrics, we could only give intramyometrally through a long needle. So that means into the wall of the uterus itself and the muscular layer of the uterus, which was really easy to do when you were doing a cesarean because you could just see the uterus and you just inject it in multiple sites and you could watch the uterus contract down. But it was even done transabdominally. I had done it once with ultrasound guidance and it was just very difficult. But fortunately now it has an intramuscular option, which makes it a much more viable option. And when most birth suites have PPH packs or PPH trolleys, which might come down to the ED, it will probably be on there and they will know how to dose it. And you can essentially dose it multiple times and it's a really good agent. Secondary postpartum hemorrhage, I guess just to quickly define, primary postpartum hemorrhage is within 24 hours of birth and usually happens straight away. A secondary postpartum hemorrhage happens after 24 hours and up to, I guess, the end of the postpartum or purpurium. There's no volume in the definition, and the amount of bleeding after birth that women have is very variable. So really you just need to be guided by their experience, unless it's obviously catastrophic, in which case it's obviously a problem. The causes of that are retained products of conception, which we can all understand, endometritis, also subinvolution of the placental site, which is just part of it undergoing its postpartum change from being a massive organ to a smaller organ. Other things include missed genital tract trauma, molar pregnancy, and then other issues. I think for the exam, the only way this will come up is either with a differential or a really severe case. So a bit like a primary postpartum hemorrhage, a lot of the treatments can be similar. So in these cases, you certainly can rub the fundus and expel any clots and do bimanual compression. You can use the uterotonics again, and these women will go to theatre for hemorrhage control if that's not taking care of it. One of the syllabus points is drugs in pregnancy. Everyone's probably quite familiar with the categories from A to B, 1, 2, 3, C, D, and X. The ones that I used to always have trouble with were essentially the B categories, and what they refer to is a group of medications where there is not much human data, but there is animal data. And between B1, 2, and 3, B1 occurs where the animal studies showed no damage, so the animal studies suggested it was safe. B2 is when the animal studies were poor, and B3 is when the animal study showed damage. C category is, I guess, would include opioids in late pregnancy. So we know that it has some, harmful effects. And D and X are medications that tend to be avoided completely. So that's more or less the entire ACEM syllabus. I do think there's some value in just touching off a few more topics that we'll do now before we wrap up. As I said, this is obviously a long talk. Some of the details may be a little beyond what you need as an emergency clinician, but I'm hoping that it will just form a foundation to your study and I guess a central place you can come back to review concepts. Okay, so these are the extra topics we're going to talk about that round out the rest of the syllabus. First one is bedside ultrasound in early pregnancy. And I think if you drill it down, it's 3 questions. 1, is there free fluid? 2, is there an intrauterine pregnancy? 3, does that pregnancy have cardiac activity? Firstly, we're all good at detecting free fluid. On the left, it shows some free fluid in the pouch of Douglas, and on the right is an image you've seen previously, which shows some fluid in Morrison's pouch, which indicates a larger volume hemiperitoneum. So that alone can be helpful, as we've discussed before, in the setting of shock. Is there an intrauterine pregnancy? This has been studied and shown that emergency physicians do it really well. And, the concept here is that if you can rule in an intrauterine pregnancy, you effectively rule out an ectopic pregnancy. And the only caveat to this is the women with assisted fertility, where there's a sort of unacceptably high risk of heterotropic pregnancy. To have a look at the progression of an IUP in first trimester, there's some images below. Essentially, the first thing you see is a gestational sac. And that is, you can see on the left there, you get the hypoechoic black circular area of fluid with the surrounding hyperechoic ring and endometrial reaction. So that's the first indicator that there's probably a pregnancy. The yolk sac you see within it on the first image is the first definitive sign of a pregnancy. So if you see a gestational sac with no yolk sac, then that is not diagnostic of a pregnancy. And then as we progress along, the next thing you tend to see is often referred to as the signet ring sign, where you have a tiny fetal pole on the yolk sac. Looks a little bit like a ring. But if you zoom up, you can often see cardiac activity on that tiny fetal pole. The next, you have a more obvious fetal pole that you can detect cardiac activity in. And then as you get to the last image, you see a much more defined fetal pole in early pregnancy. It's probably 7 or 8 weeks. Is there cardiac activity then determines whether that pregnancy is viable. As I said, it's usually visible with tiny fetal poles. The heart rate is the same normal range as late pregnancy, although early pregnancy tends to have a higher heart rate. If you do have someone who has a intrauterine pregnancy with a fetal heart rate less than 90, that's much more associated with ultimately losing the pregnancy. Using 2D imaging in M mode is the preferred way to calculate rate. You can just visualize the heartbeat and count it. We tend to avoid, just due to the ALARA principle and trying to avoid heating the fetal pole, we tend to avoid using, color Doppler to measure heart rate. Quickly on molar pregnancy, it's a form of gestational trophoblastic disease. It might come up on an exam where there's an ultrasound report. They tend to present with either early pregnancy bleeding or significant hyperemesis. The ultrasound findings are clearly abnormal. There's clearly no fetal tissue that's obvious there. Some forms of molar pregnancy can have some fetal tissue, but it's not necessarily something that I would expect or any of you should be thinking about looking for. Essentially, all you need to know is that women need a formal ultrasound and inpatient investigation and management. And even general O&G departments tend to not manage these independently. They often there's a state register and gynae-onc expert that does all of the advising on these patients acutely. Ovarian hyperstimulation syndrome is an important condition to understand. It is a complication of fertility treatment and occurs largely because the ovaries are stimulated to increase egg production. What happens is you get an excessive production of pro-inflammatory cytokines like vascular endothelial growth factor, and what happens is you get increased vascular permeability and third spacing. You also get large swollen ovaries that are at risk of torsion, so severe lower abdominal pain, that is something you need to think about, but most of the complications are in and around the third spacing. It isn't common, but these women come with bloating, nausea and vomiting, breathlessness, swelling of their legs, vulva, reduced urine output. The investigations are largely things you'd expect, like baseline bloods and an ultrasound, and the treatment is mainly supportive in around defending the intravascular volume. And there's some discussion about that there. These patients get supportive care, and in some cases, things like paracentesis are done for significant ascites. We discussed pregnancy of unknown location before. I think this is actually very examinable and certainly is very relevant to your practice. Essentially, it occurs when you've got a woman with a positive pregnancy test and a transvaginal ultrasound can't locate the pregnancy. Remember, in terms of levels of beta-HCG, we expect to see a normal intrauterine pregnancy if there is a beta-HCG greater than 1,500 and we're using a transvaginal scan, or greater than 6,000 if we're using a transabdominal scan. The truth is you can typically see pregnancies at much lower levels than that, but these are arbitrary cutoffs. And the other side point to that is that ruptured ectopic pregnancies, failed pregnancies can all occur with HCGs much, much lower. So it isn't correct to not organise an ultrasound if the HCG is less than 1,500. Now, in terms of what can happen with a pregnancy of unknown location, so these are either a normal pregnancy that's too early, an ectopic pregnancy that you can't quite see yet, a failing pregnancy, whether that's intrauterine or ectopic, or in some cases we just never see the pregnancy. But the management tends to be with serial beta-HCGs done every 48 hours with the idea that a normal pregnancy, the beta-HCG tends to double every 48 hours, although the numbers aren't quite this simple, which we'll go into, and then ultrasounds at intervals like weekly. I guess the important thing to understand is to overlay the clinical state of the patient. So if they're very well, then most of these are managed at home, obviously with specialist input via an early pregnancy clinic. The on-call O&G consultant or registrar is clearly required, but if the patient looks unwell, has got a lot of pain, then it's clearly not appropriate that they are sent home. Just a bit of an indicator on how you can look at the beta-HCG doubling time and what that likely suggests. There's a bit of a flow chart here that's used in a lot of early pregnancy clinics where you'd expect a viable pregnancy if the HCG is rising more than 2/3. If it's falling or not rising very much, we think about ectopic pregnancy, or if it's failing a lot, we think we're probably dealing with a miscarriage. And depending on those results and the patient's symptoms, they can have ultrasounds, another HCG in 48 hours, or if concerned, they can have a diagnostic laparoscopy or an endometrial sampling. Vaginal breech birth is something I'm sure you all hope to not experience. I guess historically, a lot of you were potentially born via a breech vaginal delivery, but that's becoming less common now since an RCT called the Term Breech Trial around 2000 found there was increased perinatal risk. So the flow-on of that has been it's done less commonly. Practitioners are less experienced, which further reinforces the fact that it's not done commonly. To understand the risk, I'm sure you can all imagine that in a normal head first or cephalic birth, the head is the largest diameter that needs to pass, and so the cervix needs to fully dilate to allow the head to come through. If you have a breech birth, particularly if it's preterm, there can be a very different size body versus head, and then the body could be delivered through a partially dilated cervix, and the head can become trapped and blocked from delivering. So the entrapment of the aftercoming head is one of the main concerns of a breech birth. Some advice I was given from an old obstetrician when I was training was just to sit on your hands and stand mum up, and the baby will probably deliver themselves. One of the important aspects of the mechanics of labour is the baby adopts a flexed position so that it is the smallest possible diameter, and touching the baby actually leads to a Morrow reflex or an extensor response, which will then necessitate hands-on manoeuvres to perform a breech extraction. So that's the idea of hands off the breech, and even use gravity to help by standing mum up. We will talk through some of the manoeuvres. I've got a video to show you, but hopefully if you notify O&G, have mum stand up if she can, and try not to touch the breech, get a fetal heart rate, then hopefully by the time there needs to be some assistance with a breech extraction, then someone from O&G is there. And I guess the other thing to mention is just the baby is likely to require resuscitation. This video here is just going to show the spontaneous birthing of the breech. And like a cephalic presentation, it's very reasonable to just let the woman slow down a little bit at this point to allow some perineal stretching. It's useful to just guard the baby and be there to support the body in case there's a precipitous delivery. But in general, we're hands off the breech. The legs will often flick out or can be flicked out, and then the baby will start to descend. And the best way for this to happen is with the back facing up, or at least the back facing the maternal belly. Now, sometimes the shoulders can be tricky. This is called a love sets maneuver, whereby putting your hands on the bony parts of the fetus only, you rotate the shoulders to an AP diameter. It just allows the delivery of the shoulders and the arms. Now, this model's a little bit tricky and stuck. It's usually a lot easier than that. But again, just a gentle rotation with hands on bony prominences to prevent solid organ injury, and then a gentle delivery of the shoulders. The last manoeuvre is called the Munro-Smellyvite manoeuvre, and in this case we're just allowing a flexing and delivery of the head. So 2 fingers go on the malar prominences of the child's face. Historically they were in the mouth, and then the baby's just rotated up and onto the mum's abdomen. Another topic that is potentially examinable but is an important one for you to understand as the supervising consultant of a department is that minor abdominal trauma in late pregnancy is important. First of all, the woman needs a proper trauma assessment before focusing on the baby. But just what's important to understand is that with relatively minor trauma, as we discussed earlier, women can have a placental abruption. But then one condition you may not have heard about before is feto-maternal hemorrhage, which is a condition in which there is fetal hemorrhage within the placental unit that doesn't cause external bleeding or obvious clinical signs and is only picked up with prolonged heart rate monitoring. So what tends to happen if the mother doesn't seem majorly injured, and this happens when they've had an older kid kick them in the belly, they've fallen and hit their belly, or they've had a deceleration in the car with a tight seatbelt. These are all times that you need to realise they need prolonged monitoring, and they tend to get a continuous CTG for often 4 hours. And it's only after hours do you tend to see a deterioration in the fetal well-being from the almost subclinical or sneaky condition, which is feto-maternal hemorrhage. The abruption's obviously a bit easier to pick. They can get some vaginal bleeding or have uterine irritability or tenderness, so that's a bit easier. And in the setting of fetal compromise, these women are delivered. Postpartum fever is something that is in the syllabus. It's important to understand that while endometritis is a common cause of this, it's important to have a good systematic approach and a broad differential. Again, especially outside of first world countries, but worldwide, sepsis is, a big killer of women postpartum. In terms of the different causes of fever, they can, as I mentioned, have endometritis or a genital tract infection. They can have venous thromboembolism as a cause for fever, UTI, pneumonia or atelectasis if they've had a cesarean, a surgical site infection, which can be the cesarean scar. It could be an intra-abdominal collection at the site of a cesarean. It could be vertebral osteomyelitis from an epidural. It could be a infected perineal repair, or it could be mastitis or a breast abscess. So it's important you have a structured differential for these. In terms of endometritis, it obviously has a spectrum of severity and can occur with or without retained products. It's very difficult getting an ultrasound and being sure about retained products postpartum because there can be a lot of uterine debris that can then almost set a woman on a path of more intervention. But the more unwell a patient is, the more investigations you should do, and it's more likely they'll get a uterine evacuation if there's some suggestion of retained products. There's a variety of different causative organisms, and it can be polymicrobial. And I guess in terms of assessment, the things that you might see are some lower abdominal pain or foul-smelling discharge or increased bleeding. The systemic signs you'd expect, and also uterine tenderness, I think, is a very good sign. The inflammatory markers and blood cultures and vaginal swab are obviously pretty obvious. And an ultrasound, as we discussed, something that probably to be careful with if a woman presents with very mild symptoms, but beyond that, it's very acceptable. In terms of treatment at the more severe end, then these women are going to need empiric IV antibiotics, sepsis supportive care that doesn't need to be explained to this audience, and evacuation of the uterus if there's retained products. And there's some options for antibiotics there that are reasonable. The last topic we're going to talk about, and I realise it is in the resuscitation part of the syllabus for special groups, is maternal ALS. Because it is covered elsewhere and it's a topic where there is much better access to education, I'll just go through it briefly. I guess it's really important that you understand the maternal adaptations to ALS, and they are that it's important to do manual uterine displacement to the left, and that's thought to be better than tilt. It's important also to establish effective ALS because we probably all understand this is a group of patients where we might need to consider doing a resuscitative hysterotomy. I've not personally been involved in one myself, but I can imagine from a resuscitation logistics point of view, it's obviously going to be highly challenging. So I think getting manual uterine displacement and a small team executing ALS at a high level is important to then progress on to a resuscitative hysterotomy. Now, the consensus guidelines for when to do it is essentially any time the uterus is above the umbilicus or the pregnancy is above 20 weeks. If you dig a little deeper into the literature, it's probably that there's not much benefit in that 20 to 24 week group, or at least that 20 week group to fetal viability threshold. But for the exam, I think just use 20 weeks. And I think clinically, if you don't know the gestation, the umbilicus is a very reasonable marker. Beyond that, in advanced life support or cardiac arrest, the treatment is the same. The 4 H's and 4 T's, the use of defibrillation, the use of ALS drugs, there's no difference in the algorithm. In terms of timing of a resuscitative hysterotomy, what you'll hear a lot is start by 4 minutes, baby out by 5. That's obviously super easy to remember, but I think it's pretty challenging to do. There's somewhat useful data. It's obviously not perfect data, but it's probably the best we'll ever have, that there is largely just a linear reduction in fetal and maternal outcome after the onset of arrest, and there isn't a big life-changing shift at 5 minutes. Interestingly, I think the question that philosophically you need to ask yourself in your consultant practice is how late into a resuscitation might this be helpful? And there are case reports of maternal survival over 30 minutes into an arrest, and newborn survival, at 30, 45 and 57 minutes. And the bracketed 30 and 45 minutes there, these are babies who had follow-up neurologically from a development point of view to 2 and 4 years. So they did do very well. It's completely fair to suggest that these women probably were just very hypotensive and had a low flow as opposed to no flow state. But I guess when someone comes into the ED with CPR ongoing and in cardiac arrest, in inverted commas, this is going to be almost impossible to pick. So it's probably a fair bit of data for our cohort. Equipment and anatomy-wise, the image on the right is purely meant to demonstrate that whilst it is a big procedure, hopefully a never or only once in a career intervention, in term pregnancy, there isn't much between the skin and the baby. There's obviously skin, subcutaneous tissue, scarpus fascia, rectus sheath. You've got to split the rectus abdominis muscles. You've got the peritoneal cavity, and then you've got the uterus. But really, there aren't any major organs in between, is what I'm trying to say. Now, the bladder is very possibly going to be injured in this. The bowel may be injured, but these aren't a priority. You don't need to worry about them, and you need to have that, I guess, plan in place that you're happy to proceed, and just don't let the fear of these organs that are fairly simple to repair, stop you from executing this procedure. From an equipment point of view, I think it's worth having 2 scalpels or having one and having someone get another one. The reason is it's very common in the operating theatre that we'll use one scalpel for the skin and then use a fresh scalpel for everything beneath the skin. And that's because the skin actually does blunt these instruments a lot. That's probably going to be made even worse by the fact that you don't have, an assistant doing a good job of doing counter traction to really maximize the scalpel's ability to make an incision. So just have in the back of your head, 2 scalpels is probably ideal, because if you only use one, as you get to the uterus, you're probably going to have a difficult time cutting smoothly. Sharp scissors or shears are useful, an extra set of hands, and essentially some suction, big swabs, and whatever clamps or sutures you can get for any bleeding if ROSC occurs. And in terms of surgical steps, as I mentioned earlier, you really want someone or a team coordinating the ALS. And then to keep it simple, you really want to take your big scalpel and make a big vertical midline incision. You want to go from the top of the uterus to just above the symphysis and cut vertically down to the uterus until you're able to enter the uterus. If you make a small cut in the uterus, you're going to have amniotic fluid come out. I would just extend that with scissors, and you can actually use a hand inside the uterus to guard the baby away from where you're cutting, and then bring the baby out. And then depending on how mum is, you might deliver the placenta, pack and clamp. But really, once the baby's out, it's time to give the baby to someone to try and save the baby and to get back to working on mum. So that's obviously a long video. My hope is that it essentially forms a place you can come to revise important topics and to get some ideas, perhaps find your knowledge gaps that you can then read around. There's a lot of excellent guidelines that exist around the country that break down these topics really well. Again, if you use this QR code or go to freeobstetricexam.com, you can send that link to your friends as well that are preparing. There is a 1-hour SAQ exam. And if you've gone through that link, then you'll get the answers emailed to you. It's a PDF that you can either print and write on, or you can type into. I know this is a long process. Keep up the hard work. This exam process hopefully is nearly over for you, and I'll really wish you guys and girls all really well. So good luck.